I would like to thank Mega Online Association for their continuous support of scientific activity in Qasr Al Aini and Cairo University Medical School. And thanks a lot for Dr. Saad Mahdi for his continuous support of our scientific activity. I would like to introduce the scientific day of the Pediatric Anesthesia Unit under supervision of Professor Dr. Iman Riad. Professor Dr. Iman Riad will be the moderator of the day. I will present her for her first presentation, Pediatric Deep Venous Thrombosis, a growing problem. Welcome, Dr. Iman, and we can start the first presentation.
Bismillah ar-Rahman ar-Rahim. I would like to thank Professor Dr. Saad Mahdi for the genuine idea and the great performance in Mega Online Anesthesiology Association. And I would like to thank his team for the great effort. I would like also to thank Dr. Magid Salah for the coordination of scientific activity in our department. I would like also to thank my colleagues in this webinar and the attendees for attending this day. And I hope it's going to be very useful. Pediatric deep vein thrombosis, a growing problem. Venous thromboembolism includes deep vein thrombosis and pulmonary embolism. Venous thromboembolism is basically an adult problem with significant morbidity and mortality. It is considered preventable. Children are protected against venous thromboembolism. In recent decades, in the last 2 decades, the incidence of pediatric DVT has been increasing, and little is known about this problem. This is our pediatric surgical ICU. We are in charge of Pediatric Surgical ICU, Cairo University, Abu Rish Hospital. This was one of my patients, Adam, in 2012. Adam was a 3-year-old boy, 9-kilogram, critically ill patient with cerebral palsy. He had colon bypass, sepsis, hydropneumothorax, prolonged mechanical ventilation, total parenteral nutrition, repeated central venous line insertion, and repeated prolonged ICU stay. He had many problems. Is it possible that Adam developed deep vein thrombosis? Does he have risk factors? How to suspect and diagnose, and how to treat? The aim of this presentation is to highlight the growing problem and to highlight the main differences between adult and pediatric venous thromboembolism. Anesthesiologists and pediatric intensivists should be aware of risk factors, complications, prevention, diagnosis, and treatment. Children are protected against deep vein thrombosis. Pediatrics are not miniature adults. The frequency in the community is 1/10 that in adults. But in hospitalized children, the incidence increases much, to 100 to 1,000 times. In critically ill children, the incidence is much higher. Children are protected against deep vein thrombosis due to developmental changes in the hemostatic system and due to comorbidities increasing with age. In 2009, Raffini et al. Demonstrated the increasing problem over many years from 2001 to 2007 in hospitalized children in the United States. The increasing incidence of pediatric venous thromboembolism is attributed to better care of sick children, increased central venous catheter insertion, newer imaging modalities facilitating diagnosis. Complications include acute complications, pulmonary embolism, catheter occlusion and loss of venous access, infection, chronic complications, may include recurrence, post-thrombotic syndrome, and also treatment of deep vein thrombosis by anticoagulants can result in problems such as major bleeding, osteoporosis, and heparin-induced thrombocytopenia. Concerning pediatric pulmonary embolism, it is rarely fatal. Recurrence has low incidence, and failure of recanalization, approximately 50% in cases show failure of recanalization in spite of using anticoagulation. Post-thrombotic syndrome is also a problem. Pain, edema, and decubitus sores may occur in the limbs affected by deep vein thrombosis. Costs associated with venous thromboembolism are disproportionately higher in children compared to adults due to long-term complications. Patients may live 50 to 60 years suffering from post-thrombotic complications. Therefore, it is very important to detect patients at risk. It is the role of anesthetists and pediatric intensivists to know, to prevent, to diagnose, and to treat such problems. And we have to concentrate on prevention. For DVT, there is a combination of hypercoagulability, stasis, and intimal injury. In children, a risk factor can be identified in 80 to 90% of cases. Compared to adults, only 50% of cases we can detect a risk factor. In critically ill children, a median of 2 risk factors exist. The presence of central venous catheter is the single most important risk factor for DVT in children. At least 85% of cases of thrombosis in neonates are related to central venous catheter. In other age groups, 50% of cases are related to central venous catheter. So we have to concentrate on prevention of central venous catheter related thrombosis. It was found that femoral catheters are more associated with thrombosis compared to jugular and subclavian catheters. Percutaneous and multi-lumen catheters have higher incidence. It was found that peripherally inserted central catheters have lower incidence of deep vein thrombosis. Ultrasound guided insertion is useful. Heparin bonded catheters useful in reducing DVT. This is peripherally inserted central venous line. Other risk factors include central venous line dysfunction and central venous line related bloodstream infection. And there is a correlation between infection, central venous line dysfunction, and central venous line thrombosis. Certain bacterial or viral infections are associated with this problem. There is a bimodal age incidence of deep vein thrombosis occurring in young age below 1 year and more in neonates and in adolescents. Other risk factors include dehydration, potent congenital thrombophilia, congenital heart disease, vasopressor, mechanical ventilation, recent surgery, certain medication, including total parenteral nutrition, multiple medical conditions, history of previous deep vein thrombosis, family history of thrombosis, and cancer. Cancer is a major risk factor. There is 600 times higher incidence in cancer patients and more risk in acute lymphoblastic leukemia, lymphoma, and sarcoma. Trauma patients have low risk. The risk is negligible in trauma patients, and there is no need for prophylaxis in trauma patients. If we come back to Adam, we find that he had many risk factors. He was critically ill. He had cerebral palsy, colon bypass, post-surgical patient. Septic, he was septic. He was in mechanical ventilation for a prolonged period. He was on total parenteral nutrition. He had repeated central venous line insertion, and he had repeated prolonged ICU stay. How to detect central venous thrombosis or deep vein thrombosis? Signs and symptoms depend on the area of the body affected and the degree of venous obstruction. High index of suspicion is required to diagnose deep vein thrombosis. Other possible presentation, central venous line dysfunction may attract our attention to the problem. Central venous line associated bloodstream infection, and it is usually confirmed by ultrasonography. This is the gold standard for diagnosis. However, we should concentrate on asymptomatic cases. Many cases are asymptomatic. For every case of clinically apparent deep vein thrombosis, there are 8 asymptomatic cases. Nearly 50% of cases of pulmonary embolism in children result from unrecognized deep vein thrombosis. The routine use of prophylactic anticoagulation may not be the best option. The presence of central venous catheter is the single most important risk factor for deep vein thrombosis in children. Role of anesthetist: strict aseptic precautions during central venous line insertion, ultrasound guided central venous line insertion, avoid femoral percutaneous lines, switch femoral to other sites as soon as possible, screening percutaneous lines for deep vein thrombosis, avoid larger multi-lumen catheters, use of heparin bonded catheters may reduce DVT, peripherally inserted central catheters are useful and reduce overall central venous catheter days. We have clinical practice guidelines published in 2012 by the American College of Chest Physicians, and they recommend the use of heparin infusion, heparinized saline infusion in central venous catheters in neonates. In critically ill adults, pharmacologic thromboprophylaxis are highly recommended, but in children, this is not recommended. It's not ideal to use routine pharmacologic thromboprophylaxis. We have risk assessment tools have been developed in for hospitalized and critically ill children. This is one of the risk assessment tools, and it is recommended for every institution to have a risk assessment tool to categorize children into low risk patients, moderate risk, and high risk. Low risk patients are managed by early ambulation and good hydration. Moderate risk patients to receive physical prophylaxis by elastic stocking and compression devices. High risk patients are to be receiving low molecular weight heparin. For the treatment and management of deep vein thrombosis in pediatrics, guidelines were produced. We have American College of Chest Physicians evidence-based clinical practice guidelines published in 2012, and American Society of Hematology guidelines published 2018. Pediatric hematologists with experience in thromboembolism are suggested to manage pediatric patients with thromboembolism. When this is not possible, it is suggested that a combination of a pediatrician and adult hematologist to manage these cases. In our institution, maybe pediatric hematologist or a vascular surgeon can manage. According to American Society of Hematology, anticoagulants are recommended for symptomatic patients with deep vein thrombosis. This is a strong recommendation. Initial anticoagulation with unfractionated heparin or low molecular weight heparin for at least 5 days. And for patients who are to be given vitamin K anticoagulants, they should start it from first day, and when we reach suitable INR, we can stop heparin. What about the catheter? What about the catheter? Do we have to remove the catheter when we diagnose deep vein thrombosis? If the catheter is functioning and needed, it is suggested not to remove the catheter. Now, if the catheter is not functioning and unneeded, it is recommended to remove the catheter. But when to remove the catheter? Do we have to remove it immediately? It is suggested at least of 3 to 5 days of anticoagulant therapy prior to its removal. The evidence supporting most recommendations for antithrombotic therapy in neonates and children remain weak, and most recommendations are based on extrapolation from adults, and in some circumstances, such extrapolation may be inappropriate. Most recommendations are weak. Further studies are needed to form a clear understanding of the risk factors, prophylaxis, and management of pediatric venous thromboembolism, and to guide anesthesiologists in decreasing such problem. If we come back to Adam again, now we knew the risk factors, and Adam was found to have deep vein thrombosis. He was found to have right atrial thrombus, brachiocephalic vein thrombosis, and Adam received low molecular weight heparin, 1 milligram per kg twice daily. This is another patient. This is another patient in pediatric surgical ICU. She was 12 months old, 12 kilogram female with recent surgery. She received the femoral central venous line intraoperative, and postoperative she had sepsis, and she received total parenteral nutrition due to failure of feeding. And on 8th postoperative day, she had a swollen right lower limb, and she was found to have femoral deep vein thrombosis. Upon consulting a vascular surgeon, she was found to have femoral deep vein thrombosis, and she received anticoagulation, and the catheter was removed, and she received subclavian central venous line. This is the last patient. In conclusion, children are protected against deep vein thrombosis. In the last 2 decades, the incidence of pediatric deep vein thrombosis has been increasing. A risk factor can be identified in 80 to 90% of cases. Central venous catheter is the single most important risk factor. We have to know the role of anesthetists and pediatric intensivists in decreasing such problem. Strict aseptic precautions during central venous line insertion. Ultrasound guided insertion is recommended. Avoid femoral percutaneous lines except out of necessity. Switch femoral to other sites as soon as possible. Screening percutaneous lines for deep vein thrombosis. Avoid larger multi-lumen catheters. Use of heparin bonded catheters may reduce central venous line related deep vein thrombosis. Reduce overall central venous catheter days. For neonates with central venous access device, it is recommended to maintain patency with unfractionated heparin continuous infusion. Asymptomatic cases significantly more common than clinically apparent cases, and we have to take precautions to avoid this. Every institution managing children at high risk should institute an algorithm of risk assessment and prophylaxis to prevent venous thromboembolism. Current recommendations for venous thromboembolism include initial anticoagulation with unfractionated heparin or low molecular weight heparin for at least 5 days. According to the American Society of Hematologists, it is suggested not to remove the catheter when it is functioning and it is needed. When it is functioning and needed, when we have to remove the catheter. When it is not functioning and not needed, we have to delay the removal for 3 to 5 days. Further pediatric studies are needed to form a clearer understanding of the risk factors, prophylaxis, and management of such patients. Thank you.
Thanks a lot, Professor Dr. Iman Riad, for this nice presentation. And we can, if there are any question for Dr. Iman and regarding the presentation, I have a question here. Do you recommend for using ultrasound daily in the intensive care for critically ill and high-risk patients?
It is not recommended to use it daily for detection of deep vein thrombosis. Not for every day, not daily to use ultrasound. Yes, it is not. It may be used for other reasons, but not for this purpose. There is no recommendation regarding this. The routine screening is not.